Hello and welcome to the Straits Times webinar, COVID-19, 6 months on, lessons learned. I'm Salma, Khalik, Senior Health Correspondent at the Straits Times. First, some administrative matters. To submit a question, click the Q&A button at the bottom of your screen. We'll try to have as many of your questions answered as possible. If you have difficulty viewing the presentation, exit the webinar and try using a different browser. Singapore reported its first case of COVID-19 on January 23rd, exactly 6 months ago. Since then, a lot has happened, with global infections topping 15 million. More than 630,000 people have died. The three experts with us today bring together different expertise as we look at what we now know of the disease and what the future holds. Professor Ying is Dean of the NUS Hock School of Public Health. Ying is an epidemiologist. That's someone who studies healthcare trends. He has been following the pandemic right from the start. Professor Ooi Eng Eong is the Deputy Director of Duke-NUS's Emerging Infectious Disease Program, and COVID-19 certainly fits that bill. Eng Eong has also been working on tests and vaccines for the coronavirus. Professor Dale Fisher is a Senior Infectious Disease Expert at the National University Hospital. Dale also chairs the World Health Organization's Global Outbreak Alert and Response Network Steering Committee and was part of the WHO China team that was in Wuhan earlier this year to study the outbreak. Dale, since we have you on now, could you tell us, why are people infectious before they get any symptoms? For most infectious diseases, the viral load is high only when people get sick. Before they get sick, the viral load is low, and so is the risk of them spreading the disease. So why is this one different?
I don't really think we know why it's different, but it certainly is. And we knew about this from about, I guess, mid-February, that the transmission dynamics are heavily affected by the viral shedding and at the time. So some studies showed that actually from the time there were symptoms, the viral load actually started falling, which meant that the peak was at day zero. It's really about, I guess, the relationship between the host, being the human, and the virus. Another example of that is why people can be asymptomatic at all yet have the virus, or indeed people with mild disease can be shedding just as much virus as those with severe disease. So it's the host needs to be factored in, but we don't know the actual reasons, but it really affects our interventions once we know that it can be infectious right at the start.
So you're saying that when somebody is sick, the person is actually less infectious than before the person got sick?
Yeah, I mean, for the 15 to 20% of people that get very sick, yeah, their viral load can be a lot less than it was earlier because other factors have come into play then, such as the immune system and thrombosis and scarring, the whole inflammatory process.
Right. But do we see this happening with other infectious diseases, or is it unique to COVID-19?
Oh no, certainly some conditions. Chickenpox is well known for being transmissible in the 48 hours beforehand. Probably flu. So it's not. It's allowed. It's allowed in the microbiologic world.
Right. So it's not that unusual, but it's not a very good sign for the rest of us.
The point is, it makes it really hard to control, which you probably and the rest of the world has noticed that it's very hard. It's common to wake up and feel a bit snuffly from the aircon or something like that, and you wonder if it's a flu or not. So often people aren't sure if they've got symptoms, but the whole knowledge that's been published, even out of Singapore, that you can spread it when you have no symptoms, that's a real game changer and makes it really difficult to control, which is why the social distancing, even between well people, the mask wearing, these things are critical in the control.
Right. Can we turn to something slightly different? You know, there's now talk of something called long COVID, meaning that the effects of the illness can linger for months. Do we see that in patients here? How common is it? And what are the effects that linger on? And how long do people suffer from them? Is it for a few months or is it a lifetime problem?
Well, I'll again say, remember, this is a novel coronavirus, and we've only been seeing cases in Singapore since January 23rd. And in fact, in the general community, we've only had, less than 1,000 cases. So establishing the extent of these phenomenon is on the table. It's something that is being looked at in Singapore and obviously elsewhere in the world. How many, so what you're talking about is a sort of a ongoing lingering fatigue. And this is definitely anecdotally reported. It's actually anecdotally reported in a lot of infectious diseases. People getting irritable bowel after a gastro, for instance, and it might take 6 or 12 months to settle down. There are considerations of this lingering fatigue. I don't believe it's that common. I think it's probably more common if you've had a serious, severe case. Is it forever? We'll see. We'll see when we get to, when we've known a bit more about it for a few years. I think what's a bigger concern is people that have had a severe pneumonia. How much of that is going to turn into long-lasting disease and scarring and things like that. So that'll be very important to establish in the years to come.
You know, I came across a website by a 27-year-old woman. She's in Britain, and she had a very mild attack of COVID-19. But after that, she's had difficulty breathing, getting tired very easily. So she started a website for other people who are getting lingering effects. And some of the stories there are quite scary because it's not happening to the older people who had severe illness, but to the younger people who had mild illness. Eng Eong, have you come across this before?
Actually, this happens in dengue, right? So we've been trying to understand this for, as a consequence of some of the viral diseases. And as Dale said, the exact reason why some people have this lingering and very drawn out cause of illness is not known. It could well be that it's all part of the immune response, and whether some people are able to resolve the inflammation, some people perhaps aren't so fortunate. But we haven't still been able to understand everything about this. So much remains to be learned.
What actually surprises me is that generally, I think the older people are the ones who suffer worse with COVID-19, and yet they don't seem to be the ones who are getting this lingering disease. So I found that a bit surprising, but is that normal?
It could be the difference between the pre-infection state versus the post-infection state, right? So maybe those people who are more active in their daily lives, they sense that difference more acutely than, say, someone who's perhaps live a more sedentary lifestyle. So it may well be this impression of I'm not back where I was before I fell sick kind of impression.
Right. Dale, anything to add?
Yeah, I think, Salma, you've just got to be a little bit wary of anecdotes. This needs to be collated in a scientific way. It needs to be kind of validated as objectively as possible. Yeah, so it is a lot more complicated, and this is a place for research, really.
Well, I hope the researchers among you will do something about it, because that is quite a scary development. Eng Eong, talking about research, there are a number of vaccines going into human testing now, including the one that you are doing at Duke-NUS. Could you tell us what makes a good or a successful vaccine? Is it its effectiveness, the lack of side effects, how long it lasts? What are the criteria for deciding?
Right. So ideally, the vaccine simulates everything that the virus would do. So it goes through this, the infection process. It's a little bit like, I guess the analogy is you remember much better if the entire scenario plays out before you as a video rather than seeing snapshots of the various events in stages, and then you try to piece everything together. So the best vaccine, therefore, is a weakened SARS coronavirus 2 or SARS-CoV-2. Right? You weaken enough so that it won't cause disease, but not so weak that it wouldn't cause infection. Unfortunately, that's way too difficult to do, right? Because this is it's a fairly a serious infection to have. So how do we tweak the virus to weaken it? We don't know enough. So therefore, all the other vaccines that are being developed now are basically making use of just a part of the virus, predominantly the spike protein. And the spike is like, if you like, it's the key that the virus uses to unlock to get into a cell. Right? So if you can block that, then the virus can't get in, it won't cause infection. So all the various vaccines that are in clinical trial now are making use of variations on how we show the immune system the key that the virus uses so that the immune system will remember and recognize it the next time it sees it.
You know, vaccines on the market are not 100% effective, right? Some are 90%, some are 80%, some are even lower than that. So if a COVID-19 vaccine comes and say if it's 70% effective, would you say it's good enough to be used?
70% effectiveness is actually very good. Even a natural infection would not give you 100% protection from a second infection, right? So I mean, okay, whether COVID gives you lifelong protection or short-lived protection, that's something that's being debated. But anecdotally, there's still that tiny minority that despite having had a natural infection in the past, they go on to get it again. Not everyone will have that, but that's basically tells you that there's no such thing as 100% protection. So having 70% actually is good, but I think at the end of the day, the control of COVID isn't going to rely on vaccine. It isn't going to rely on drug. It isn't going to rely on measures like social distancing alone. It's probably a combination of everything that we can throw at this virus. So at the end of the day, if we have a 70% efficacious vaccine versus a drug that can prevent development of severe disease, as well as treatments that can prevent severe complications, I think if you put all of this together, we can at least try and keep this problem at bay and go back to as much of our normal lives as we can.
You know, the advantage of a vaccine is that you keep people from getting sick, so they don't stress out your hospital system.
Absolutely.
Finding good medication is important because you save lives, but then these people do get sick. They do end up in hospitals occupying beds that other people with other illnesses will need.
Absolutely.
But Eng Eong, could I come back to that 70%? It means that if 10 people get a vaccine, all of them feel that they're going to be very safe because I got the vaccine, I can go out, I'm fine. But what you are saying is 3 of them actually are not protected at all. So they think they're safe, they go out, but they are not protected. Right.
That's exactly right, Salma. But the way the vaccine works is it isn't just at the individual level. So the person who falls into the 70% and protected against infection, that's great. They won't get it, right? But actually they go on to protect the others who don't actually develop immunity. And that's this whole concept of herd immunity. And the idea is that it's a chance event, right? So for instance, if under normal circumstances and COVID looks that way, that one person will pass it on to about 2 to 3 people, right? And so, and that's because of the context that we make in our social and daily lives. And that's how physical distancing works. You remove these contexts. And so one person then would pass it on to fewer than one person, the outbreak dies. So now if in a vaccinated population, even if you don't stop the social context, one person will come in contact with 3 people and can potentially pass it on, but actually 2 of those are already immune. You can actually only pass it on to 1. That will have a big impact on reducing the outbreak and keeping it well below what the kind of transmission needed for the virus to cause these pandemics.
Right. Now, Dale Eng Eong, usually vaccines work better on younger people. They tend not to be as effective in older people. And yet COVID-19 is more dangerous for older people. So if you are going to vaccinate, say, the entire population, and it's 70% effective, the 30% who will not be protected are likely to be the older people, who are the ones who are more in danger. So does that really make sense? As doctors, what do you people say?
If the young people are solidly immune, then they would not pass the virus on to the older people, even if they are not immune or not vaccinated, right? And that's how herd immunity works. Actually, it works so well that that's how we got rid of smallpox. We eradicated smallpox, right? You just have to vaccinate 80% of the population and the virus will not have the chance of causing epidemics. Likewise, how we maintain immunity against, how we keep this measles, mumps, rubella, and all that at bay so far, is to keep that a high level of our population, but not 100%. So about 95% of the population vaccinated with MMR vaccine. Then the 95% will protect the remaining 5%. And that's how it, and so on and so forth. So I think we don't need to have 100% immunity in Singapore. We just have to have enough to stop the virus from replicating. And it looks like, given that this virus spreads from 1 to 3, I suspect that 50 to about 75% efficacy, if we vaccinate everyone, will be sufficient to completely eliminate outbreaks in Singapore.
So Salma, that will be important in the strategy for the vaccine. Once we get vaccine, we're not going to suddenly get enough vaccine for the whole country. We'll get a certain supply. So you might have to discuss, do we vaccinate older people or those that are immune suppressed? Or do we vaccinate those that are looking after them and those that work in a nursing home, for instance? Nearly all the nursing home outbreaks are a result of a staff introducing it. So in fact, this is an important discussion in terms of the strategy, because you might think it's, let's just do all the immune suppressed and the elderly, but that may not be the most rational thing.
Yep. So logically, we should vaccinate all the older and people with problems, but you're saying that may not be the ideal way. Who would you vaccinate, Dale?
Well, if it attenuates disease in older people without full protection, that would be an advantage. But I would certainly like to vaccinate all the people that work in a nursing home, for instance. That would be a top priority. But we need to get the vaccine first and understand how it works, and the whole issue of vaccinating younger people also brings up the whole immune response and the Kawasaki syndrome side of things as well, which is a whole new world in terms of safety.
Sorry, could you explain that? Are you saying that the vaccine could cause more problems?
Not if it's analyzed properly, but if it's rushed. This is what concerns me a lot, is that there'll be a demand to shorten the phase 3 trials, and instead of doing it on 30,000 people, you do it on 2,000 people, rush it through and start producing it. This would be a risk, I would think. I don't know what the others feel.
Right. I think Ying has raised this before to say that if the first available commercial vaccine, say, protects 50%, but there are 2 or 3 others that could protect higher numbers, people may still rush out for the 50%, and then the others will not get fully developed. Is that also a potential worry?
I definitely think it is, but I'm happy to hear what the other says. The issue with having a rushed vaccine that it's suboptimal is that the world tends to gravitate towards that as the first solution. And that creates a lot of challenges for the other vaccines that are still undergoing trials and undergoing tests. They may end up being much better than the first vaccine, with perhaps lesser side effects and higher efficacy. But because the world has shifted its attention to the first vaccine that is released, that is why in many parts, Dale's concern is exactly right, that the first vaccine has to be properly developed with the necessary considerations for both the effectiveness as well as the safety.
Right, so first may not be best. Eng Eong, do you agree with that?
Well, if you look back at the history of polio vaccine, the first vaccine that came out was the Jonas Salk's inactivated vaccine, which is given by an injection. That vaccine stops people from getting poliomyelitis, the paralysis, but it doesn't stop people from becoming carriers of poliovirus. So it's only the second vaccine that was developed by Albert Sabin that was swallowed, and it's a live vaccine, that prevented the carriage, right? And over time, what happened was that the oral vaccine became more accepted because it was easier to administer and all that. And that's how we've successfully controlled polio. But now that we've entered this polio elimination phase, where most parts of Western Pacific have got no more polio transmission, then using a live vaccine becomes a little bit of a problem, because this virus is still alive, so it can still cause infection. So now we're all switching back to the inactivated vaccine, again, because of public health reasons. So I guess a lot of this is all about risk benefit. At the point where you need the vaccine, what's the problem? What's the size of the public health problem? And that shapes how the vaccine policy and the choice of the vaccine. My view of the different vaccines and whether the front runner will then slow down those that lag behind a little bit, I don't think will be a major problem, because of one, the size of this problem. If this was like SARS in 2003, then yeah, I think the number of people affected, the number of countries affected, it wasn't that large. So maybe you have this competition effect. But now this COVID-19 has gone around the world. I mean, everyone on the planet is susceptible to this infection. So I think the front runners would not be able to produce enough to vaccinate everyone. So there will always be demand. The demand will outstrip the supply. And also, with regard to the vaccine safety, I agree that if you look at it from the way we've developed vaccine, the normal timeline from getting from a point where you start working on a vaccine to getting into phase 1 trial is about 3 to 5 years. We're doing 3 to 6 months right now, right? And so, how can we shorten this journey? I think the short answer to that is we understand a lot more about the side effects of vaccine today than we did in the past. And a lot of this you can now measure by looking at genes, by looking at how you respond to vaccines, and that pretty much predicts the safety or shapes the safety profile. So I think whilst we shorten the time, and there's this concern that we're rushing things, but I also want to balance things up by saying there are a lot of molecular tools now that weren't available to us even 5 years ago, so that we can now use to evaluate how safe vaccines could be.
Something that's come up over the past couple of months is the fear that antibodies do not last very long in some patients. So if that happens, the same would happen with the vaccine. So does that mean if it's true that the antibodies disappear after a few months, a vaccine really is not much use?
Okay, so this is a very interesting question, Salma. The reason why I think that the antibodies don't last in patients who have had COVID-19, especially the mild patients, the reason is because the virus switches off some of our immune response. Makes sense, right? The virus needs to grow. It needs to come into our body, and it needs to grow, and then it needs to get out to get into someone else. If it doesn't do that, it dies, it's dead, right? So in order for it to grow, it needs to switch off some of our immune response. Otherwise, our immune response will kill it too fast. So one of the things that we know now that it switches off is the interferon response. And this interferon response is needed to shape our antibody response. So if the virus switches off the very genes that our body relies on to develop antibodies, then you can understand why people who have had COVID-19 sometimes don't make very good antibody response. In the vaccine, we don't have that. We just put a part of the virus, not the whole virus. So the part that the virus uses to switch off the interferon response is not in the vaccine. So I think the vaccine has a chance of producing an immune response or antibody response that is more robust than getting wild-type infection. The other answer is that the antibody is just one arm of the immune response. The other arm is the killer cells. And I think the killer cells are also very important. And that killer cells is pretty long-lived. So a colleague of mine, Antonio Bertoletti, looked at SARS patients 17 years after they recovered from SARS, and we still find a lot of killer cells against SARS.
Not antibodies, the killer cells.
Yes.
Right. So interferon, that's why some hospitals are using it, the inhaled version for patients, right?
Yes.
To block that. Yes.
Yes, because that's what the virus switches off, so you supplement it as a form of a drug.
Right. Ying, could I turn to you now? Singapore has had very few community cases over the past few days. Does this mean that it's now pretty safe for us to socialize more, you know, going out, eating out, meeting friends, going to the cinemas or parks or beaches?
Well, the situation in the community does look promising these days, but I think it's important to remember all the pains that we, the people, the country had to go through to reach this current stage. And the restrictions during the circuit breaker, during phase 1, and even some of the restrictions that still exist right now in phase 2. So right now, we are allowed to socialize more. And with not more than 4 other people at each time, we're allowed to eat in hawker centers, in restaurants. Parks and cinemas have opened, of course, with the safe management measurements put in. So in many ways, yes, we are allowed to socialize more now. But Salma, you asked the question whether it is safe for us to do so. I like to think that if everyone keeps to the rules that it's not just Singapore that keeps repeating, the World Health Organization and many other public health experts in other countries have always emphasized mask wearing, social distancing, maintaining personal hygiene, and of course now observing the safe management rules that public spaces or workplaces have put in place, it actually will be quite safe. But the problem comes when there are people who tend to be a bit more relaxed about following rules. Like in today's news, in Straits Times today, there were reports about people coming together in groups of 10 or even 18. So in those settings, that is when you're much more likely to encounter someone who's a little bit more adventurous. They may feel a bit unwell, but still think that, well, it's fine for me to go out, watch a movie with my friends, come together. It's just a sniffle, it's nothing serious. What's the chance I'm infected anyway? And that is exactly when it becomes less safe. So coming back to about all the activities that you mentioned, those activities, whether they are safe or not, fundamentally depends on you, me, everyone. That if we remember that actually when you wear a mask to go outdoors, it is not normal. It is something that we have to do right now because there's an outbreak happening. We are in DORSCON Orange. It is a last resort to wear a mask to go out to continue your activities, because it means that there is still community transmission of an infectious disease out there. The world is in fact facing an ever worsening pandemic. So I like to come back to the fact that we are allowed to socialize and we are allowed to regain some normalcy in our life now. But the reminder is really, let's not go overboard, meet up with different groups of 4 other friends a few times each week. And I myself, for example, will minimize going to places that are indoors where there are large crowds interacting for an extended time.
Yeah, you know, the government says don't go out unless you really need to. And then on the other hand, it says you can meet 4 friends for lunch. So I haven't met my friends for a long time. You know, we sometimes meet and gather and gossip, etc. And when you're eating, you take your mask off. Right? So that becomes a danger. So then the question is, should I go out? Should I, you know, meet them 2 or 3 times a week? Or should I not see them at all and still continue staying indoors, even though it's allowed?
So this is the bit where, in fact, I was just reading some of the questions that were posed. There was also a comment, a question specific to the Singapore Tourism Board, encouraging us to participate in local tourism activities as well. I think it all comes back down to how often do we participate in such risk-taking adventures, or whether we are working within a sphere that we are fairly confident that is going to be fairly safe. For example, I meet up with my parents for a meal, perhaps one day every fortnight. Every 14 days, I meet my parents to have a meal together. I don't think that that is a high-risk activity, but would I do that while at the same time meeting many different groups of different friends? Every time I interact with more people, you can slowly think of it as you are slowly adding up your risk. And if I know that most of the days, I minimize my activities to coming to work, going shopping for supermarket, grocery shopping, I reduce my risk significantly based on my own activities. And that is when I decide I can still participate, meeting a few colleagues together for lunch, because those colleagues are people that you meet regularly. And if you're meeting them for lunch, I don't think that's going to be extremely high risk. It is going to be a difficult compromise. And I think if all of us continue to just stay at home, clearly the situation will be very well in check. But I think there will be a strain both on the economy as well as on our own mental wellness.
Right. So you're saying if you meet the same groups of people all the time, it's fine. But if you're meeting different people every day, then you're putting yourself in danger. Dale, have you been going out?
No, I'm a big fan of working from home. No, but
He's an infectious disease.
I've been out a couple of times in the last week to a restaurant, and I thought it was, I enjoyed it more than usual, actually. The tables are well spaced. There's only 4 people at a table. We ordered on an iPad. So the only person walking around, unless you had to go to the toilet or something, was the waiter. So the service was very efficient because there's not so many people. And for restaurants, I think the only way they can keep their numbers up is by getting turnover up. So it's a very efficient service. So yeah, I think we can do this safely, as YY was saying. It's about living with the virus. We can't all lock ourselves at home, but we can do things as safe as possible. And because we're not all in shutdown, there will be the odd case, but with good behaviour, we can have a small number of cases, small clusters, no super spreading events, and we can go on like this fairly indefinitely. It's much better than the alternative is everyone finds it party time. Oh no, now we've got to lock down again, which is what you're seeing overseas.
Right. So everybody should behave and we can continue like this better. But Ying, you mentioned the STB. You know, the travel sector seems to be the worst hit right now because the airlines are not flying as they usually do. We don't have the tourists coming in. There have already been some retrenchments. Do you expect a lot of that to be happening? A lot of people out of jobs?
I think, firstly, I'm not an economist, but I will give my views on this. I think based on the economic figures, it is clear that there are some sectors of the economy, specifically hospitality, tourism-related travel, aviation, that will be the most affected. And Minister Chan Chun Sing yesterday already mentioned this as well, very clearly. I think these sectors remain pretty much at a standstill, but we have to see why this is happening. Those sectors are currently being affected to allow the rest of society and the rest of the economy to continue functioning. So I think there will be sectors that will be put on hold, and this is where retrenchments will increase. But I think in Singapore, at least, there are all these grants for retraining and other workforce support that will help to reduce this somewhat, compared to many other countries at the moment who do not even have any financial support or retraining schemes available. But I think still saying that Singapore has schemes in place to help people, it's not going to be real comfort to a person who has just lost his or her job. But I think worldwide, I do see that this problem of retrenchment is going to go up because it is not possible where businesses are put at a standstill and yet people's livelihoods still continue. This issue on inequity is going to increase significantly because there will be some sectors that are now being forcefully kept shut to allow the rest of the economy to function as per normal. And how do you explain this to people that you have to lose your job so this other group of people can continue working and earning a job? And I think this inequity would be something that countries will have to put in place the necessary safeguards to maintain that social cohesion.
Right. Thank you very much, Ying, for raising that point. I believe some of our audience has been sending in questions. So let's see what they would like to ask you. Right. What are the possible side effects of the vaccine that we should know about? Would the efficacy of a vaccine be affected if the virus mutates? And are we likely to see the first vaccine become available for use in Singapore?
I can take that. So the common side effects of vaccines are pain, local side events like pain, swelling, and all that, which will go away in a day or so. Then sometimes in some people, you also get this flu-like illness kind of thing. You get a fever, feeling a bit tired, a bit of muscle ache perhaps for about a day, and then it should go away. All that's because of the immune response, the immune system responding to the vaccine, right? So it's not because the vaccine is not safe, it's just a side effect of your own immune system.
So there's nothing dangerous?
Yeah, no, and it'll go away. I mean, at the very most, some people may have to take a Panadol or so for a day, and that's it. It'll go away.
No, I can live with a Panadol if it gives me protection. But are we likely to see a vaccine in Singapore? How soon can we see that?
I think at the soonest, and I say this as an extreme optimist, at the soonest it'll be about this time next year. I don't think it can get any faster than that. And even then, by this time next year, we'll probably have data that the vaccine works, how it's going to be scaled up enough to vaccinate millions, to roll it out and actually, line people up and vaccinate them and all that. All that is going to take additional time. So it may take a while. Everyone's trying to work as hard as they can and see if we can speed things up. But I think even if we can get it by this time next year, the whole journey having taken only about a year and a half, it's a tremendous improvement from the 10, 15 years that it normally takes for a vaccine to get to the market.
Right. Eng Eong, I believe Duke-NUS is going to start human trials.
Yes.
Can we volunteer? Can all
absolutely.
1,000 of us here volunteer for your human trial?
Absolutely. Well, the first trial only requires 108 people. So a clinical trial can be split into different phases. The first phase is to ask whether the vaccine is safe, whether the side effects can be well tolerated, and whether it produces the kind of immune responses that we want to see. So that we don't need a lot of people. We just need enough to be able to see these events. When we get into phase 3, hopefully which will be the end of this year, that's where we can make a difference, because phase 3 then asks whether this vaccine will work. Now, as I said, I think what is missing in the world right now is there's no lab measurement that can tell us that if you have this much antibody or if you have this much killer cells, you will definitely be protected against COVID-19. That information is just not available. But a lot of people are trying to tackle this, and it may entirely be possible that by the end of this year, we will have some inkling what those numbers are, so that when we go into phase 3 trial in Singapore, we can shape it such a way that it not only answers our question whether it works, but it also protects the people, right? So we can turn phase 3 into our advantage, and that's
Sorry, if it works, I don't get that. If it works, then it should protect, right?
So the hardcore evidence that it works is you take the people who have been vaccinated versus those who didn't get the vaccine, and show that those who got the vaccine had far fewer disease cases than those who did not get the vaccine, right? That's the acid test. So what I said earlier about a lab test is like a surrogate marker, but it's entirely possible that we'll get the surrogate marker before we get that acid test result, right? But if we do get that surrogate marker, we can shape the phase 3 trial in such a way that more people benefit from being a part of the trial than if we hadn't known that, right? So in other words, there is advantage for Singapore to be a part of a phase 3 trial. So
Right.
clinical trial is not so much just an experiment. I do this as a guinea pigs. Actually, all that work has been done in the lab. By the time we get into clinical trial, we pretty much, most of the time, we know what we're doing.
Well, at least they know they are safe.
Yes.
How effective is what they'll find out, but they will be among the first to get the vaccine if they're in your trial.
For our vaccine, yes.
Yes. But I wanted to ask Dale, what are the chances of Singapore being able to participate in phase 3 trials for other vaccines that have been developed?
Just to go back a little bit, I think what Eng Eong is explaining is important for listeners to grasp. I think the public is being really poorly treated in information about vaccines. What Eng Eong's saying is that there's a preclinical phase, there's phase 1, 2, 3 trials, then there's got to be post-marketing surveillance. And there's going to be a lot of twists and turns in the next 6 to 12 months. Just like there's been so many twists and turns in the last 6 months, don't think vaccines aren't going to be the same. Plenty of things will go wrong, but all we're doing is hearing, another vaccine's gone into clinical trials. Now, let me tell you, there's 130 odd vaccine candidates, 24, I think, in clinical trials, and 3 or 4 have gone through to phase 3. But every time anyone's got some news, they know that this will affect their share price, their pre-sales, their funding, and the good news is flooding. And long sufferers of COVID in the public, and all of us, grasp that information and get so excited about a vaccine. And I would really prefer this be unwound a little bit to concentrate more on what we were talking about at the beginning, which is living with the virus and ultimately being helped a lot by a vaccine. But even after the vaccine comes, we're still going to have cases. We're still going to have little clusters. It'll just be a lot easier to manage with a vaccine.
Well, a lot easier to manage is better than what's happening in some parts of the world.
I want a vaccine too, but it seems like everyone's holding their breath until there's a vaccine, and that's just because they get good news every day.
Yes, I guess it holds out hope that normal life, can resume. But back to the question, what are the chances of Singapore taking part in vaccine trials for the 100 and something candidate vaccines?
I'm not sure. I'm sure everyone's open for business. Eng Eong would know better than me.
Yeah.
Right. So yeah.
Vaccine companies will want to go to places where there's a lot of transmission, where there are a lot of cases. Because to know whether a vaccine works, you need these events and being cases. So the more there is, the smaller the trial needs to be, the faster you get the results. If there's not many cases, then you need a lot more people and you need to study over a much longer period. So obviously Singapore isn't, in that sense, a very ideal place for a vaccine because we actually control our disease, as Ying pointed out earlier, very intensely, right? But as I said, I think for me, the getting part into this vaccine trial stage, there's already some benefit by the time we get to that stage and we know all the attributes of this vaccine in humans, that is safe and that it generates the right immune response. By the time we get to phase 3 trials, I think there's some benefit to the Singapore population. I think the other question I wanted to tackle quickly on that slide just now was this idea of a virus that will mutate out with this vaccine. The chances of that happening is extremely small because of the way the vaccine's been designed, right? That the immune response isn't just against one part of the virus. You're looking at the entire spike protein. So it's not just the tip of the spike, you're looking at the entire thing. And you're coming in from multiple angles and attacking this virus. So we're not putting all our eggs in one basket, so that if the virus slips through, that's it, where we have no more defenses. So in what we're doing, there's a lot of redundancy that if one fails, we have others that will pick it up. So I'm quite confident that mutation is going to affect this vaccine.
Right. So we can still remain hopeful for a vaccine, but we should not hold our breath and think that that's the magic bullet.
Right.
What other questions do we have? Let's take a look.
Maybe something for YY. He's looking a bit lonely there.
I'm actually learning a lot from Eng Eong about the vaccines.
All right. This one looks straight up YY's. Somebody is asking, realistically, when can we go on holidays again? Minister Lawrence Wong has said that leisure travel is not likely to happen this year. Is it going to happen next year? YY, what do you think?
So this is not very fair. Eng Eong gets all the good news questions and I get to give all the bad news.
You mean the answer is no?
Unfortunately, I honestly don't think that we will be going for leisure travel this year or even until the early parts of next year. And we have all this discussion around green lanes at the moment. We have a green lane arrangement with China. We have one that's coming up with Malaysia. At the moment, this green lane discussions have been very much confined to business-related travel or essential travel. Mass market tourism travel, it's still not in the picture yet. And my opinion is that it will not happen for the end of, for the rest of this year. It's not going to happen. As much as I want to be able to travel, my kids have been asking whether we can go to different places for fun. But I don't think that it will be possible. Not because we don't think that we can manage the situation very well in Singapore, but it's the converse of when we go out, we end up being exposed to many different factors that are beyond the control of myself. And it could happen on the plane, it could happen when I'm at a hotel, or it could be at the local tourist attractions. So even if we do have an arrangement with a partnering country, perhaps New Zealand, that is controlling the situation very well, we have seen how quickly the situation can change. If we look at what's happening in Hong Kong, what's happening in Australia right now, the situation changed very quickly within a matter of 2 to 4 weeks. So realistically, I will have to be the person to convey the bad news. Eng Eong, I leave the good news to you on the vaccine. When it comes to tourism, mass market tourism, regrettably, I think we will not be able to travel out of Singapore for the foreseeable future.
Right, so if we want to go overseas over the next few months, we should seriously think about Sentosa.
Yeah.
Or Pulau Ubin. Pulau Ubin is a fantastic place. I just came back from Pulau Ubin, and it's a very beautiful place that I strongly recommend.
Does either of you, yeah, Dale?
I think what YY says is realistically the truth, but I don't think it needs to be that way. If Singapore should be able to get itself into a position where if you're a contact of a case, that you're in quarantine. So you could not leave the country. And if we're good at finding our contacts, let's say we get to a point where 90% of our cases are already in quarantine, for instance, they were preemptively in quarantine because they were identified, then that should give another country the security of knowing that we're not putting any contacts or high-risk people on a plane. So that country should accept it. Now, if, for instance, we would be comfortable with China, because as soon as they get a case, they're very, very kiasu. They lock down the whole area, swab everyone within a whatever radius. We could be comfortable that China's not going to send any to Singapore. So I think if governments could speak to each other, have arrangements, I don't think we need a 14-day quarantine. I don't think we need testing at the airport. Health insurers should be able to offer health insurance because it's a safe transaction. It's not 100%, but it's very safe. So I think YY is right, because governments and insurers won't get their act together, but it need not be that way.
So you think it may be safe to go traveling sometime later this year, with maybe to certain places only?
I don't think it'll be feasible, because I don't think the governments will act this way, because it's a risk. I don't think insurers will travel insurance will support it. It's a big area of work, but I think from a health perspective, it can be managed without all the quarantines and testing.
Right. Okay. So forget your travel plans then.
Yeah.
Next question, please. Right. Many countries are reporting a resurgence in the number of cases. Health Minister Gan Kim Yong has said Singapore must be prepared for a second wave. Do you agree? And if so, when will this happen? And can it be stopped? Second wave in Singapore. Who wants to take that?
Well, I can start, and then happy for Dale and Eng Eong to add on as well. So second wave in Singapore, I think we will work very, very hard to avoid having a second wave. And I think we have seen some of the resurgence in different parts of the world. I mentioned 2 places earlier on, Hong Kong and Australia. But actually, if we understand what happened in those countries that led to the resurgence, it was actually, there were a number of protocols that were not followed properly. There were a number of people that were let into the country without the necessary quarantine. And I think that in Singapore, I'd like to be a little bit more optimistic here that presently our rules are still very well kept to. the people generally have been very cooperative. If you're on stay-home notice, if you are required to spend 14 days after you return from travel overseas, people generally follow those rules. Social distancing, mask wearing, again, I could see that when I'm out in public, most of the people follow those rules very properly. And if everyone are able to keep to the rules well, we have a very good chance to reach that level that they'll talk about. We may have 10, 20 community cases every day, but most of our activities can resume because the risk that we pose to each other, it's going to be kept to a minimal if we follow the three rules we talk about always: mask wearing, personal hygiene, social distancing. And so I do think that Singapore right now, we are equally susceptible to a second wave. If people start to be a little bit cowboy in their behavior, taking risk unnecessarily, if there are a lot more gatherings of 10, 20 people coming together at homes for parties, for meals, that increases the risk. But generally, if we are able to keep to what the government has put in place, especially also safe management practices at the workplaces, the chance of having a second wave can be minimized. And I think this is where we are aiming for. And I think that even if we do see a resurgence in the community, given some of the measures that we put in place, we are in a very good position to figure out where those resurgences are coming from, which are the risky activities. And I suspect if we do see a resurgence, the first option on the table is actually a sectorial shutdown rather than another comprehensive lockdown like a circuit breaker. That's how I feel about it. But Dale, Eng Eong, what are your thoughts as well?
Wait, what do you mean by a sectorial shutdown?
So I think we have seen how certain gyms or activities have a higher risk because they were not kept to, certain protocols were not kept to properly, and those were shut down for a period of time. And I see that happening potentially if we now start to see, for example, it's just an example, that cinemas, there are clusters that are now linked to cinema goers, and we see that that could be a place for spreading, and that's where certain, we may need to consider shutting down cinemas. But I highlight that that is just an example. I wasn't using that as a definitive case. What we have learned very clearly from places like Japan and South Korea are nightlife entertainment spots like clubs, discos, pubs. Those would be very bad idea to open up at this point in time. And I think Singapore at the moment, as far as I know, those places remain shut.
Yeah, I can add to that, that, you know, in public health is all a lot of, the way to think about it is just all risk benefit, right? For everything that we do, the circuit breaker, you know, shutting down various, shutting down travel, shutting down even business travel and all that, it helps to control the disease, but at the same time, it costs society, it costs, you know, Singapore in order of billions, as we're now learning, right? So, you know, and so sometimes the medicine can be more painful than the disease. So we just have to calibrate that. And I think Dale also alluded to this, right? That, yeah, and Ying as well, that, you know, we can go out now, but just don't overdo it. So that what we're doing is now trying to calibrate and live with the virus. So if the number of cases go up again and we think that the trend is not looking good, then we have to go back to some level of, you know, essence of some of the circuit breaker. Perhaps, as Ying pointed out, we don't have to do it across the whole country. We can do it in clusters, either by you know, the building or the geographic radius in which the cluster is occurring, or, you know, through a particular workplace or something like where these contacts are happening. But I think the other thing that perhaps would be useful for everyone to understand, and certainly the public who's at the tail end of this to appreciate, is that, you know, because of this having to adjust to this risk benefit, things change. Even the control measures change. So you could ask, oh, you know, actually we didn't have to wear masks at the beginning of this outbreak. Now we have to wear masks. Now, what if it comes a day when, you know, we say, okay, we can do without masks, and then after that, coincidentally, second wave happens, and they say, okay, that was wrong. I don't think it's a matter of getting it right or wrong. Again, we're trying to adjust to this risk benefit. And so sometimes, in other words, this whole thing is very dynamic, it's very fluid. And we just have to accept that things will change. It will not be static. Right? What works today may not work tomorrow. Maybe we need more, maybe we need less. But it doesn't mean that what we're doing today is wrong or what we've done in March is wrong. Right? So it's just what we're doing at the moment, given how prevalent the disease is and the cost to society.
Dale, anything to add to that?
I'll try and not repeat what they said because I agreed with it all. The important thing is it's not about the numbers, and that's what you learn from a place like Melbourne or Victoria, where they had their numbers right down, but that was because of lockdown basically. And as soon as the lockdown was over, it's really, it must be so disappointing, but you know, they've got I think 45 nursing homes infected. They've got meat packing plants infected, all the hospitals, all the places that we know about. And what it shows is that even though their numbers were low, and that's just a close to home example, it's obviously many examples around the world, that a lockdown and low numbers doesn't count. It's when you go back to your adapted society. And I think Singapore has shown that it can. You'll be aware of YY in our publication last week that really listed a number of points that Singapore really ticks all the boxes, that we do have that strong public health response. We do have good community behaviour with a little bit of help from people in the crowd that, what are they called? The SG ambassadors.
Yes.
Which I tell you, it's easy to come across them. They're in every hawker stall and things. So and that's very important, just to keep people on track. And but yeah, when you start changing the community behaviours by loosening restrictions or whatever, that's when you take the risk. And I agree. Singapore, is it likely to make a decision like open all the nightclubs and you can stay up all night? I hope they don't. Could there be a super spreader event? Well, I do worry about if fully opening the hawker stalls and then seeing a whole residential block get infected like we've seen elsewhere. I think that's a risk, because Singapore is a very dense country. So I hope we don't keep pushing the borders until we do have a second wave. I hope we can temper that, and I think we will. I think we're in one of the safest places, actually.
You know, when you talk about taking measures, wearing masks, safe distancing, in most countries in the world, safe distancing means 2 meters apart. In Singapore, it's 1 meter apart. Why is that? And is 1 meter good enough?
I don't think there's a magic distance that, 1 or 2 meters beyond which we're definitely going to be safe. I think at the end of the day, it's all about practicality. The distance, the physical distance is one thing. The mask wearing is another thing. Good hand hygiene is a third thing. So I think each of these things all add up, and they help to really, enable this effectiveness in control measure. I don't think that any one of its own will work.
So, and certainly, I'll share a couple of jokes. My sister tells me she's standing in a shop in Australia, and so she stands 1 meter or 2 apart from the next person, and then someone comes and stands in between them. A friend of mine in Geneva, waiting to catch a bus, stands back, so someone else goes and stands in front of him. So, I think it just makes sense to wear a mask, because saying if you can't socially distance, I'd probably like to see them get taken off when you're walking through a park or something like that. I think that would be okay. But I think if you're in any sort of built-up area, you just have to wear a mask.
Yeah. So just behave sensibly. Let's see what else people are asking. Dormitory residents have been isolated and quarantined for several months already. Why are we still reporting several hundred COVID-19 cases from the dorms every day? Dale, I think you'll have to take this one.
Oh, is this when I do this and freeze?
You know, because they say the incubation period is about 2 weeks. So if I have a double incubation period, it's 1 month. Now it's several months and the dorms are still reporting cases. Why is that so?
The first cases were early April. It's a question of scale. When you've got, so there's over 1 million workers altogether, but let's talk about the 300,000 in the 43 purpose-built dormitories. Ideally, you would be taking out the positive cases and putting them in a central supervised community care facility for younger people, and older people or sicker people can go to hospital. That took a little while to ramp up because we didn't have that capacity. So that probably took us time before we could actually manage all the positive patients. But in the meantime, there was still some spread happening, and normally also you would take every contact and put them in a single room for 2 weeks to see if they manifest disease. That's what we tell the rest of the community. But with the density that the foreign workers live with, there was no capacity to isolate everybody. So it's been extremely challenging and complicated to work through 43 dormitories that had and 300,000 men in the way of it. So the strategy was very novel. A lot of it was around taking out the older people or those with comorbidities and making them safe. And part of this is why we've seen 48,000, I think, cases now and 27 deaths. It's absolutely staggering. The rest of the world's going, how did you do that? And that was part of the reason. I'm sure there would have been a lot more problems had older people gotten infected. So there is still some transmission obviously happening, but a lot of the dorms, out of a combination of serology and PCR testing, we're now clearing, but it's been slow. I think there's about, of all the dormitories, including the factory converted dorms and things, there's about 900 of them are now, I think, are clear. About 250,000 men are clear, and there's it should all be over with in weeks, maybe a month. But it's been a marathon that we didn't want to have, and every effort's being taken to make sure that we're not sending infected men out and creating new protocols to make sure those that didn't get infected, there's no new clusters. There's even new designs for dormitories that are being built so that we don't have this again.
Right, so we knew what we should do, but we did not have the capacity to do it. However, what we did right was to remove the people who were older and at higher risk. And because of that, Dale, you're saying we have been able to keep mortality down.
Yeah, it's a huge part, but also every dormitory was assigned a medical team, whether it be from hospitals or polyclinics, and they were there every day, 7 days a week. So people could report sick, whether it was for their for respiratory illness or whether it was for other illnesses. So you could go to some of these dorms and there's just always doctors, nurses, allied health, volunteers, community volunteers. So yeah, there was a lot of attention and a strong priority on not dying more than transmission, I say.
Right. Now we've got 79, 80 questions on queue, so I think we have to go to the next one. See how much time we can answer all the questions.
Are there any yes, no ones?
Right, airborne transmission of COVID-19. So they want your view on airborne transmission in the community and how can we mitigate it? What can we do in aircon buildings, for example, if the virus is airborne? So this is for Eng Eong and Dale, I guess.
Yeah, I don't mind taking it. there's been a lot of talk about this. There's definitely two schools of thought. I'm in the more popular school of thought that airborne transmission is not a major driver of this. I think it can aerosolize. We know it can aerosolize if you do aerosol generating procedures such as intubating or dental work, things like that. That can make aerosols. Aerosols are defined as particles that are less than 5 microns in size, so 5 millionths of a meter. They can, in theory, suspend, drift, and there's a few conditions that do that. Chickenpox, measles, these have got R0s, reproductive numbers of over 10, 12, 15, 18 on different reports. And that's what you see with airborne conditions. Even TB is airborne, and that's one of the top 3 infectious disease killers, with a third of the world probably exposed. So we don't see that with COVID. We don't see this sort of level of transmission. Now, it's never been cultured in a droplet, although PCR fragments have been found. There's a preprint that came out yesterday suggesting that they might have cultured it, but that's still under scrutiny. And even that paper suggests that it's very, very few, and probably below an inoculating dose, enough virus to cause disease. So I think it can. I think it's probably very uncommon, and we shouldn't be obsessed about it in our strategies in terms of mask wearing and social distancing.
Right.
I fully agree with Dale. I think this is it's certainly possible that it can be transmitted by the aerosol route, but the likelihood of that happening in real life, I think, is very small as well. I think that Dale brought up this point about this inoculum. What it means is that you need a minimum number of viruses to get into the body before a disease or at least an infection can happen, and then after that a disease can ensue. If you fall below, if there's not enough virus and the number of viral particles to get into the airway is lower than that, it's not going to happen. Nothing's going to happen. So that's why measles and chickenpox are so it can be transmitted by the aerosol route, because you need so few particles and you'll still get disease. Whereas I think for SARS-CoV-2, you need, it doesn't happen in the same kind of that small number of viral particle in inoculum as would as measles and chickenpox. And so therefore, when even if you do have a COVID-19 patient and he's coughing in an office building, is expelling virus into the aerosol. If the virus were to be sucked into the air conditioning system, goes through the filters and all that, come out, this thing, the entire process would have diluted the virus so much that whoever then manages to inhale it would not have enough particles to cause the infection. So the way virus spreads through the air vent and all that, it's a nice theoretical thing, but in real life, it seldom happens that way.
Right. So therefore, actually, plane travel is also quite safe in a closed environment.
I think even for tuberculosis, I mean, those events there was transmission in the plane, the number of people that actually do catch the bacteria from a TB patient is actually very small, right? And you cannot even then, you cannot exclude the possibility that the transmission actually didn't happen, say, in the bathroom or something, the patient went to the bathroom followed by the other passengers, and that's where the transmission actually occurred through contact rather than through the aerosol route. So I think, like I said, the prevention of COVID is a number of things that we use in concurrently: mask wearing, social distance, physical distancing, good hand hygiene, avoiding close contacts and all that. And all those things all add up to reduce the risk of transmission.
Right. So we need not worry if you're working in an air-conditioned building. It's quite safe. Next question, please. Do you think more effective public education campaign is necessary? More in-your-face graphic images of droplets from breathing, talking, shouting, or when COVID-19 patient looks like problems?
Well,
In other words, do we need to educate the public more on what to do and what not to do?
actually,
Why? Yes.
my frank opinion is that given what we have gone through for the past 6 months, it will be very difficult for people not to realize what are the right behavior. And I suppose the public education here, we have been doing that every day. If you have newspapers, if you subscribe to the Straits Times, which I hope all the audience will have, on the front page, you have daily reminders of what to do, whether you're an elderly, whether you're a person going to work, the features, the symptoms to look out for. So I think the education side is actually there. But I suspect over time, there's this degree of fatigue that will set in, inevitably. Even in the best society, there will be a degree of fatigue if people have to stay indoors, people have to keep wearing masks, they have to maintain a certain degree of distancing between their friends, their colleagues as well. And I see that trying to address some of these issues around fatigue and around the behavior will be relevant. And perhaps that's where the question comes in on what do we do next to address this degree of fatigue? And do we run a risk if now there are people, increasing number of people deciding that, well, I'm not going to wear my mask, or I will take more risk, I will have more social gatherings. And I see that to be a very pertinent issue. And this is where the constant reminder that the situation is not normal. What we are facing right now is not normal. The fact that we are having this discussion right now over Zoom instead of being in a studio is not normal. And I think all these are daily and regular reminders to people that it is a painful experience that we're going through now, not being able to go overseas for holidays, having to maintain a degree of distance, wearing a mask. The bit about wearing a mask, I know many people are quite upset about it, particularly if they have to wear a mask immediately after exercise. So those are reminders that we are not going through a normal time. So I don't think that it is to do with public education per se, but more to start to address some of the pain points that individuals or collective, the masses are feeling with respect to the fatigue. It could be even mental fatigue around this constant pressure that something is happening out there. If I do this, am I exposing myself to higher risk? And am I participating in a high risk activity? Most people will not think that going supermarket shopping is a high risk activity. But right now, there's all these reminders, including from all of us, to say that, well, going supermarket is something that is potentially risky. You have to do your safe management, safe entry, and you have to wear a mask and so on. And I think that over time does grind down a person's resilience.
Right, so it's not lack of knowledge, it's the fatigue that we need to fight. And after a while, people tend to let go. Dale, yes.
Yeah, slightly different take, although not completely different. I agree completely with fatigue, but this whole engagement of the community and education has to be strategic and never underestimated. And it's obviously why we're all here now, because we believe in the importance of it. Because the community has a lot of questions, and we are here because we believe we can give clear, honest answers. And questions will keep coming up, and that's how you maintain trust and confidence and therefore behavior. But you also have to be doing it in a number of different ways, because doing it on, how do you approach the younger people, the older people that might only speak a dialect? How do you approach, how do you message to prisoners? Everyone is in a different setting, and everyone needs their own special issues addressed. So I think it actually is a lot of work. I think fatigue is a major concern, but I don't think we should ever forget about the importance of keeping information up with people so that they get the right understanding.
And on
Right,
this
so
point, maybe I could just add on. Dale has a series of fantastic cartoons, comics.
I've seen them.
Very, very educational, and it translates very important messages in a very simple way for people to understand. So strongly encourage the public to have a look at the comics that Dale is featured in.
The COVID Chronicles.
Yes, I know. We've featured them in the Straits Times as well. You know, I do look out for them. Anyway, on the subject of fatigue, before our audience get too fatigued with our session, I think we need to close it soon. We will have time only for one last question. And the question is, how will the resurgence in the number of cases in other countries impact on the reopening local, regional, and global economies? Are we looking towards a long-time recession? Are we talking about the economy being bad for the next 12 months maybe or more? Anybody has a crystal ball? Anyone who wants to take an educated guess on this?
None of us are economists, I'm afraid.
So, okay, in that case, we will leave that question to the economists and we will have to close today's session. I personally found it very interesting. We've ranged from travel to vaccines. So for people who may have missed part of the show, this show will be available for viewing on the Straits Times Facebook and YouTube from 7 p.m. tonight. Thank you everyone for joining us. I'm Salma Khalik, Senior Health Correspondent, the Straits Times. Goodbye and keep safe.